I will introduce you, so just give me a when we're starting, okay?
Sorry, can I ask, are you just seeing the title slide here? I just want to make sure the screen share is correct. Okay, great, thanks.
Well, how are we doing for time? I'm sorry that we have 5 minutes, Angela.
Sounds good.
All right. We'll get Mei Ying to introduce you.
Sounds good.
Dr. Cassie, how much of a bio do you give them? I feel like I'm going to miss out on things.
How's your year in practice been, your first year in practice?
Yeah, it's been good. It's a bit of an adjustment, especially like for several months. But I think it's good to start. So yeah.
Yeah, it's always very different, isn't it?
It is, yeah, certainly. I think it's always like things that you don't prepare for or think about, I think, during training.
Are you doing more inpatient or outpatient work?
So I'm covering Dr. Pavlowska's clinic right now as an outpatient, and then I'm doing consults as well. And so it's a mix. And you'll be starting soon, right? And
yeah.
Well, that's very exciting. That's great.
And you're going to be leaving soon, is that correct, Angela? You said you're
Yeah, I am as of July. So
right.
it's coming up soon.
Where are you going?
I'm going on maternity leave.
Oh,
yeah.
then.
Yeah. This part isn't being recorded, right? So
I don't think so.
Okay, great.
I don't think any of the noon rounds are recorded or ground rounds.
Okay, okay. Perfect.
Yeah.
It's preparing.
I think we will start. So welcome to Grand Rounds. You can see by the screen, your screen, that today's Grand Rounds is entitled Premature Ovarian Insufficiency. A very different topic than I think many of us are used to at Grand Rounds, and certainly as internists. One of the new division members for the Division of Endocrinology, Dr. Angela Liu, will educate us today on this concept. So Angela, please.
Okay, thanks so much, Dr. Casson, and thank you very much for having me present today. So today I'll be talking about premature ovarian insufficiency, or POI, and we'll be going through some of the causes and consequences, and there'll be a bit of a focus on Turner syndrome specifically. So I don't have any disclosures. So in terms of our objectives today, so we'll start with reviewing some of the causes of POI, including Turner syndrome, which is one of the ones that I'm interested in. We'll also talk about the long-term consequences of POI on multiple systems, including bone, cardiovascular health, as well as some other systems. And to conclude, we'll summarize the treatment as well as monitoring of women with POI. So first, we'll start with some background. So what is POI? POI is defined as the loss of ovarian activity before the age of 40, and it's characterized by three things. So one, there's a change in menstrual function, either oligomenorrhea or amenorrhea, and along with that, we also see elevated gonadotropins, FSH/LH, as well as a low estradiol. In terms of the epidemiology, the prevalence of POI in the general population is felt to be approximately 1%. And in terms of incidence of spontaneous POI, the quoted rates are approximately 1 in 250 by age 35 and about 1 in 100 by age 40. There are a number of factors that affect the age at natural menopause, and this is based on a US study. But what they found was, in terms of ethnicity, for example, that POI appeared to have a higher prevalence among African Americans as well as Hispanic populations, whereas there's a lower prevalence in Asian populations. Lifestyle can certainly also play a role. So smoking is known to be a risk factor for early menopause, whereas women with a higher BMI tend to have later menopause. And along with that, there are also socioeconomic factors. So for instance, we often see later menopause in women with higher SES. Sorry, I'm just trying to share. So in terms of the diagnostic criteria, so there's a sort of clinical features as well as lab findings. So one, we would expect to see the change in menstrual function, so either oligo or amenorrhea for more than 4 months. And along with that, we would want to see an FSH that's in the menopausal range, so more than 25. And typically this is measured on at least 2 occasions, 4 weeks apart. And that would kind of give you the diagnosis of POI. So next we'll move on to some of the causes of POI, and broadly speaking, this can be divided into 4 main categories: autoimmune, iatrogenic, chromosomal, as well as idiopathic, which among women with spontaneous POI can make up a fairly significant proportion of patients. So in terms of autoimmune POI, there are generally 3 main categories. First, it can be associated with adrenal autoimmunity, which is probably the strongest association in terms of autoimmune POI. It can also be associated with non-adrenal autoimmunity. And so you can see that there can sometimes be multiple other autoimmune conditions, thyroid disorders, hypoparathyroidism, type 1 diabetes, lupus, myasthenia, etc. And so that's another category that we think about. And finally, you can also have isolated autoimmune POI. And like I sort of mentioned earlier, the strongest association is with autoimmune Addison's or adrenal insufficiency, and specifically in the context of the autoimmune polyglandular syndromes, APS1 and APS2. in terms of the epidemiology of autoimmune POI specifically, approximately 5% of women with POI are believed to have an autoimmune oophouritis causing their POI, and the adrenal origin accounts for the vast majority of cases, so approximately 60 to 80%. And up to about a third of women may also have some other concomitant autoimmune disease, like the ones that we had kind of mentioned earlier. So next we'll move on to some of the chromosomal causes that we look for when working at POI. And so in terms of chromosomal etiologies, approximately 10 to 12% of women diagnosed with POI are thought to have some kind of chromosomal abnormality. And most of these are abnormalities of the X chromosome specifically. As would kind of be expected, the rates of chromosomal POI are higher in women with primary amenorrhea compared to secondary amenorrhea. And so we'll kind of briefly talk about two very specific chromosomal causes. So we'll start with Fragile X. So this is a sketch that appeared in a book by W. Ireland in 1877. And it's thought to be one of the earliest depictions of Fragile X syndrome in the literature. And you can see in this diagram here, there are some of the more characteristic, I guess, phenotypic features of Fragile X, including like a long, narrow face with a more prominent forehead and chin, larger ears, mid-face hypoplasia with sunken eyes, as well as strabismus. So how does Fragile X relate to POI, and why do we look for this? So to start, Fragile X is considered an X-linked cause of intellectual disability, and it occurs in approximately 1 in 3,600 individuals in the general population. And the full-blown syndrome is caused by decreased levels of FMR protein, which you can see on the rightmost column in the diagram there. And so the picture here is basically showing differences between normal, pre-mutation, and full mutation within Fragile X syndrome in terms of the transcription and translation of the FMR1 gene. And so you can see here that for a full mutation, there's more than 200 repeats in this kind of specific area of the X chromosome, whereas typical or normal should be less than 45, whereas you have this intermediate pre-mutation zone where you have anywhere from 55 to 200 repeats. And you can see here that depending on the number of repeats that are present within this area of the chromosome, mRNA transcription can either be a little bit higher than normal, as is seen in the pre-mutation, or very low, as in the full mutation. And correspondingly, the amount of FMR protein in the pre-mutation is actually close to normal/normal, whereas the amount of protein in the full mutation is very low. And so specifically, when we're thinking about Fragile X in the context of POI, we're looking for the pre-mutation because the pre-mutation in females leads to an increased risk of POI. There's also this other entity called Fragile X-associated tremor ataxia syndrome, which is a possibility, but more so seen in males with the pre-mutation. Next, I'll talk briefly about the inheritance of Fragile X syndrome, which is quite interesting. So the diagram here is a fairly typical family tree, I suppose, of Fragile X syndrome. And so importantly, pre-mutations, when passed on by females, can expand to a full mutation. And the rate of this expansion depends on the number of repeats that were present initially. Conversely, in males, when the pre-mutation is passed on, they can stay the same, expand to less than a full mutation, or even regress. And so, as you can see in this diagram here, where they're showing a child who's initially diagnosed with the full-blown Fragile X syndrome as, for example, the first family member, and then their family members are tested, you can see in terms of the number of repeats, mom has a pre-mutation, so about 76 repeats that then subsequently expanded when she passed it on to her son, whereas grandfather also has a pre-mutation where the number of repeats stayed approximately the same when transmitted. And so, you know, kind of a classic family history would be, okay, maybe a child with Fragile X syndrome, mom has a pre-mutation, maybe POI associated with that, and then grandfather has this kind of intention tremor. Sometimes patients will refer to it as Parkinson's, this kind of more non-specific presentation. So in terms of the, sorry? Oh, Sorry. Okay. So in terms of the pathogenesis of POI and Fragile X premutation, the mechanism by which the premutation causes POI is not very well understood. Like I had sort of mentioned earlier, the difference between the premutation and the full mutation is in the amount of mRNA expression that we see, where there's elevated mRNA in the premutation, but a lack of mRNA in the full mutation. And because there is no association between POI and the full FMR1 mutations, the thought is that, well, perhaps this extra mRNA that is floating around may be causing some kind of toxic effect, but the mechanism and how that works specifically isn't very well understood. All right, so moving on, we'll talk about Turner syndrome, which is one of the other main chromosomal etiologies of POI that we think about. So I thought I'd start with an example of Turner syndrome in the media. And so some of you may recognize this character. So she's Edna Mode, who is an eccentric fashion designer from the movie The Incredibles. And the thought is that her character is based off of a real person, although this is controversial. But it's thought that she was inspired by this woman, Linda Hunt, who is an actress with Turner syndrome. And so in terms of Turner syndrome, what it is that it's a chromosomal disorder that affects phenotypic females with one intact X chromosome and either a complete or partial absence of a second sex chromosome. It's the most common chromosomal defect in humans and occurs in approximately 1 in 2,500 female live births. It is also associated with multi-organ involvement, which we'll describe in the later slides. In terms of the genetics of Turner syndrome, so by far the most common karyotype is monosomy X or 45XO, and that accounts for about half of cases, as you can see in the table here. But there there's either karyotypes or genetic patterns that can also lead to Turner syndrome. So you can see that there's mosaic patterns. There's possibility of having like a Y chromosome, which is important in terms of screening for things like gonadoblastoma. And some may affect more cells, fewer cells. And so there's a combination of various genetic patterns. In terms of the manifestations of Turner syndrome, there are many, and so this is a pretty long list, and so I'll highlight a few coming forward. So first, and this is more so in a pediatric setting, but children may be diagnosed with Turner syndrome if they present with growth failure or short stature. It can also be associated with endocrinopathies such as diabetes, thyroid disorders. We can see GI and hepatic disorders such as transaminitis, celiac disease, as well as IBD. Cardiac manifestations are a really important comorbidity to watch for in women with Turner syndrome, and some congenital heart conditions that can be associated include bicuspid aortic valves, as well as aortic dilation and coarctation. We often screen women for horseshoe kidney because this is also like a renal manifestation of Turner syndrome, and then they can also have neurocognitive and psychosocial issues as listed here. And finally, there are some of the phenotypic characteristics that we think about. So perhaps one of the more common things that you may read about would be things like a high arched palate, short stature, a broad neck, a broad chest, wider carrying angle, etc. And so, based on some of these phenotypic features, some women may be diagnosed, in childhood, for example. And importantly, some of the things that come up for us and relevant to this talk would be that Turner syndrome can often be associated with ovarian failure or POI, as well as gonadoblastoma in those who, more likely to occur in those who also have a Y chromosome component of their karyotype. So thinking about the pathogenesis of POI in Turner syndrome, so again, like with Fragile X, it's not very well understood, and our current understanding is based on quite an old study of 8 45XO fetuses that were examined. And what they found was that in these fetuses, that the ovaries appeared to contain a normal number of primordial germ cells up until approximately 6 weeks gestational age. After that point, the number of germ cells appeared to decrease and the amount of connective tissue increased within the ovaries. And so the conclusion was that perhaps the gonadal failure that we see in Turner syndrome is due to accelerated apoptosis rather than abnormal germ cell formation. And again, mechanism not really well known, like theoretically, could this be because of decreased oocyte survival, because of this haploinsufficiency of the X chromosome genes? It's postulated, but not very well understood. And so based on these causes, there are a number of investigations that are undertaken. For example, when a patient presents with a new diagnosis of POI with no clear etiology, and these are the recommended tests that should be done. So one, a karyotype to look for Turner syndrome, FMR1 gene testing to look for the premutation, as well as antibody testing. And so the two that we do generally are for anti-adrenal antibodies and anti-TPO antibodies. There are also various other etiologies that can contribute. So idiopathic and iatrogenic are two big ones, but there are also some kind of more rare conditions that have been associated with POI that we don't typically screen for or check for. And usually I would say that, I think most people would be diagnosed based on some of the other characteristics that we see associated with these syndromes. So next we'll move on to some of the consequences associated with POI. So this was a review paper in 2016 that kind of described some of the consequences that can be associated. And you can see that POI can really affect a wide variety of symptoms, including cognition, cardiovascular, bone health, and even mortality. So starting with bone health, we know that POI is associated with a lower bone density as well as increased fracture risk. And the mechanism of this, lower density and fracture risk kind of depends on when or the timing of hormone deficiency. And so generally it's thought that peak bone mass is attained by approximately age 30. And so if there's a prolonged hormonal deficiency before age 30, then oftentimes that can result in decreased peak bone accrual. Whereas if there's deficiency after age 30, then that can result in early bone loss. Kind of illustrating this point is this cohort study of chromosomally normal women with spontaneous POI. And what they found was that compared to controls, they had significantly lower Z scores at all three sites that we typically look at: the femoral neck, total hip, lumbar spine. And about 1/5 of this cohort had Z scores below 2.0 or less than expected range for age. In terms of her treatment, so this is just kind of a brief summary of the general treatment strategies that we have for bone health: calcium, vitamin D, exercise, not smoking, moderate alcohol and caffeine. But importantly, for women with POI, hormone replacement therapy also plays a key role. And so next I'll talk about some studies looking at the impact of HRT on bone health specifically. So this was a 3-year prospective RCT in young women with spontaneous POI to look at the effectiveness of HRT on bone. And you can see over the 3 years, so we have our controls where their bone density didn't really change over the 3 years. And then when you look at the women who were taking hormone replacement, in this case, they used estradiol and a progestin, you can see that there was an increase in bone density at both the femoral neck and the lumbar spine. This particular study also looked at whether or not the addition of testosterone would be beneficial. And essentially they found that there was no difference in whether or not testosterone was included as part of the hormone therapy. There's also more data now distinguishing between the types of, hormone therapy that is used. So physiologic hormone replacement therapy versus something like a birth control pill or combined oral contraceptive. And so this particular study randomized women with POI to either 1 year of HRT with transdermal estradiol and a cyclic progestin, or 12 months of a combined oral contraceptive with ethinyl estradiol and norethistérone. The labeling in this particular table is a little bit confusing. So the SSR is essentially referring to physiologic sex steroid replacement, which would be the transdermal estradiol and cyclic progestin, whereas the HRT is actually the oral contraceptive. So that would be the second group here. And so you can see that after a year, there was a greater improvement in bone density, specifically at the lumbar spine in the women receiving the physiologic replacement compared to the, synthetic ethinyl estradiol and norethistérone. This is another study by Cartwright showing something very similar. So this time it was a 2-year RCT, again, comparing HRT versus oral contraceptive pills. And again, you can see that there was a greater increase in lumbar spine BMD over the 2-year period in the HRT group. So next we'll move on to the cardiovascular effects of POI. And so there have been a number of cohort studies now that have shown earlier onset of coronary heart disease, as well as increased cardiovascular mortality in women with spontaneous POI. And there was a meta-analysis that was published in 2016 of 10 observational studies, which also found something similar, where POI was noted to be an independent risk factor for both ischemic heart disease as well as overall cardiovascular disease. And so ultimately, hormone deficiency is thought to drive this increased risk in cardiovascular disease. So there was one study that was done in 2004, a pretty small group, so about 18 women with POI compared to 20 age-matched controls. And they looked at endothelial function at baseline and then after 6 months of hormone replacement therapy. And ultimately, what they found was that compared to the controls, the women with POI had reduced vascular endothelial function, but that treatment with hormone replacement therapy after about 6 months did significantly improve this function. And the way that they kind of measured it was using brachial artery diameter, measured during hyperemia and in response to this substance called glycerol trinitrate to try to kind of evaluate endothelial function. Another RCT of about 34 women with POI basically randomized them to either 4-week cycles of HRT or oral contraceptive therapy for about 12 months. And they assessed their cardiovascular health indirectly by looking at their 24-hour ambulatory blood pressure as well as arterial stiffness. And what they found was that the group who received HRT had a lower 24-hour mean systolic and diastolic blood pressure over the treatment period. At the end of the 12 months, the difference in systolic and diastolic blood pressure was about 7.5 points, and there was no difference noted in arterial stiffness. And so based on that, the general kind of, both for cardiovascular benefit, we think about lifestyle modifications, monitoring of lipids, blood pressure, and glycemia, as well as early initiation of HRT is thought to be helpful from this aspect as well. We had talked about mortality differences in the beginning, and essentially the increased mortality that is seen in women with POI, one is primarily due to cardiovascular disease, but is also mostly seen in the group who had not received HRT up until the age of 45. So, based on that, we extrapolate or we think that HRT is protective up until about 45. And the study here on the right is essentially a study of women with iatrogenic POI, where they underwent bilateral oophorectomy, and they compared, or they looked at their survival rates over a number of years compared to a control group. And you can see that the group who was treated with HRT, that their survival curve is improved or closer to the reference range compared to the women with bilateral oophorectomy who was not treated, and that age cutoff essentially was at least until the age of 45. And there are certainly other factors that can be impacted or that we think about for women with POI, including neurologic changes. There's been shown to be an increased risk of cognitive impairment, psychological changes such as increased anxiety, depression, reduced self-esteem and life satisfaction. Fertility and pregnancy is a big one, and certainly one that many women have many questions and concerns about when they're initially diagnosed, as well as sexual health. So really multi-system impacts. So next we'll move on to treatment of women with POI. And so generally speaking, we had talked about HRT, and the use of HRT can be divided into kind of two main components. We have the estrogen replacement component as well as the progesterone component. And there's various formulations of each of these types of hormones, I guess. So in terms of estrogen, it can be given orally, either as oral estradiol or conjugated estrogens, though admittedly the conjugated estrogens are probably used less frequently. And then you also have transdermal options, including patch and gel. And in combination with that, we would pair that with a progesterone, either given cyclically or continuously. And so this is kind of an example of some fairly classic hormone replacement regimens. And so you can see that as the estradiol dose goes up, then we try to match that with a progesterone dose that also increases. And for women with POI, really what we're targeting is this kind of age-appropriate physiologic replacement, which would be 100 micrograms twice weekly of the patch, which is approximately equivalent to 2 milligrams of oral estradiol. And with that, they can take either 200 milligrams daily of micronized progesterone or 300 milligrams cyclically, so sort of day 1 to 12. In some cases, and for some patients, if this type of regimen doesn't work for them, or sometimes cost is a barrier, then there are also some women who choose to take an oral contraceptive pill, in which case one of the regimens that I'll often use would be something like a 21-day pack. They take two packs continuously, so 42 days, take a 4-day break, have a withdrawal bleed, and then restart. And that's kind of another option in terms of hormone therapy strategies. So that's sort of for POI in general, but certainly for women with Turner syndrome, there are additional considerations. Like we had mentioned earlier, there's multiple other comorbidities and multi-system conditions that can be associated. And so there are two big clinical practice guidelines in terms of reviewing what would be recommended for screening for these women. So this is this one from the 2016 Cincinnati meeting is sort of the general clinical practice guidelines. And I'll kind of quickly review them. So this table kind of summarizes some of the measures or things that need to be assessed regularly for these patients. So, at every visit or annually, they should have their weight and BMI assessed. They're prone to metabolic syndrome, so things like blood pressure, lipids, glycemia would be important to assess also on an annual basis. And along with some of the other things that we had talked about, so thyroid dysfunction is a common comorbidity as well. So they should have their TSH evaluated. Liver enzymes are often checked on an annual basis as well. They can be prone to celiac disease, so a celiac screen if there are suggestive symptoms. The renal ultrasound we do at baseline to assess for horseshoe kidney. They should have an audiometric evaluation because there is an association with sensorineural hearing loss as well. So that's done about every 5 years. And then ophthalmological dental evaluations, as well as BMDs that should be done at the time of diagnosis. And thereafter, it's about every 5 years. And when discontinuing estrogen, which is typically around the typical age for menopause. There's also a separate statement or guideline for cardiovascular health specifically. We know that, congenital heart disease occurs in approximately a quarter to up to half of individuals with Turner syndrome. And the cardiovascular comorbidities are really the most frequent cause of early mortality for this group of patients. And so this is a flow chart here kind of showing the recommended screening guidelines for these women. And you can see that for adults, well, kind of close to adults, so after about age 15, the screening is with, echo, MRI, and ECG. And the frequency of screening kind of depends on one, whether or not they have a history of congenital heart disease or other risk factors, and what their aortic size indexes. So if there is evidence of dilation, then typically the screening is done more frequently versus less frequently if there are no concerns. And generally speaking, if there is a history of congenital heart disease or an elevated ASI, then they're typically followed by a cardiologist as well. In terms of some of the other guidelines, in terms of adult health surveillance for women with Turner syndrome, so we had touched on fertility earlier, which is an important, I guess, patient counseling point. So oftentimes patients will want to know about their fertility options, including things like oocyte donation or adoption. The other important counseling point is that for women to be aware that spontaneous pregnancies can still occur, though rates are generally low. And POI or ovarian failure is a very typical manifestation as well. For women with Turner syndrome, if they're thinking or wanting to consider pregnancy, then a review on whether or not this is advisable and what the risks are is very important prior to them proceeding, specifically with regards to their cardiovascular health and risk of aortic dissection. We had mentioned psychological manifestations of POI as well, and there are also certain associations with Turner syndrome specifically. So there is an increased risk of social isolation, anxiety, as well as like sort of more OCD type behavior. And so, during the annual reviews or visits, it's important to review any issues in terms of workplace or relationships. And these types of concerns can often be responsive to clinical psychology support as well. So now that when we think about kind of knowing, I guess, a little bit more about Turner syndrome and some of the multiple comorbidities that can be associated, there are sort of questions about models of care and what would be the optimal way to kind of provide care for this patient population. And the guidelines now do also recommend kind of multidisciplinary collaborative care, given that there are all of these sort of multi-system comorbidities that can take place. And to kind of illustrate that, I thought I would briefly talk about a patient that I saw about a year ago who was a 19-year-old woman who had been diagnosed with Turner syndrome at a bit of a later age. So she was about 17, and she was diagnosed after presenting with primary amenorrhea. And after she was diagnosed, she underwent all of the usual screening. And so she was found to also have, hypothyroidism. She did have some anxiety. She had lichen sclerosis. She had a new mole that she was concerned about and hadn't, completed all of her, audiology screening. Cardiac tests were still pending. And she was seen with her mom, who also had, concerns with regards to future fertility implications for her daughter. And so with all of these questions and concerns, you can imagine that like a real multidisciplinary team would be required to kind of address all of these various aspects of her care. And so just, going off of that one case, you can see that multiple people would need to be involved in order to kind of provide her with optimal care with all of these different aspects, as well as screening on an ongoing basis. And so I think, she ended up seeing a cardiologist as well for assessment, given that there were questions of fertility. She was referred to a fertility clinic to explore her options. She saw an audiologist for her hearing test. She saw dermatology, given that she did have a bit of a funny looking nevus. And she was seeing, I think, a counselor or a psychologist for anxiety. So there's multiple people that are certainly involved in the care of these patients. The other part of this that's important would be the pediatric to adult transition, given that girls can be diagnosed with Turner syndrome in childhood. And, how to sort of transition or move their care from the pediatric setting to the adult setting. This is a schematic of various transition models that was actually in the Turner syndrome guidelines as well. And I would say that in BC, we have mostly the distinct pediatric and adult care systems. And so the question is how to facilitate or smooth that transitional process from pediatrics to adults. And so this particular question is an area of interest for me in terms of research. And so currently I'm working with Dr. Sabrina Gill and Dr. Lega in Toronto, looking at different models of care specifically for patients with Turner syndrome. And the comparison, or the two sites that we're looking at, is either this multidisciplinary TS clinic that's present in Ontario compared to a more distributed model of care that we currently have in BC. And specifically, we're trying to see if there are differences in patient populations, in screening patterns, referral rates, for example, to other specialists and for other testing, as well as the types of hormone replacement therapies that are used and adherence. And I think the results of this study and of studies like this would help inform us on what types of models of care would be helpful for this particular patient population, but may also be generalizable to other patients, for example, with multi-system comorbidities or conditions, and kind of the types of care that might be good in terms of promoting like a patient-centered experience. So in summary, POI affects approximately 1% of women. The etiologies, like we mentioned, include chromosomal abnormalities such as Turner syndrome, autoimmune disease, as well as iatrogenic causes. There are multiple long-term consequences of POI, including impacts on bone, cardiovascular health, fertility, sexual health, neurologic function, and more. And an important part of treatment would be the early initiation of hormone replacement therapy. And for conditions like Turner syndrome, where we have multi-system comorbidities, additional screening and multidisciplinary care is very important to kind of optimize all aspects of their care. And so I'd like to thank Dr. Gill and Dr. Lega, who I'm working with on my research project, as well as everyone else who agreed to participate in the study. So thank you very much. And thank you all as well for listening. I think we're a little bit ahead of time, but were there any questions? But I'll be happy to answer them.
Hi, Angela. This is Michelle Johnson. Can you hear me?
Yes, I can hear you.
Thank you for that excellent review of premature ovarian failure. I just had a question about the replacement, and I saw on your slide how you talked about the oral and the transdermal and then the progesterone dosing. And I was just wondering if you could comment on the use of the continuous combined regime, like if you personally feel comfortable with that. Are you concerned about endometrial hyperplasia, or if they're on continuous combined, do you do any monitoring for endometrial hyperplasia, or as long as they're amenorrheic, you're happy, but if there's breakthrough bleeding, maybe you would reassess things? I just wondered if you personally would use that regime, or do you feel like they have to have a certain amount of withdrawal bleeds in a year?
Yeah, so do you mean with the estradiol with the continuous progesterone, essentially?
Yes, exactly. Like I'm just saying, do you feel that that is an okay standard of practice? Because I think many women would choose to do continuous combined and not have a period, but are we confident that that's not leading to endometrial hyperplasia?
So usually I do recommend, like if they ask or if they don't have a clear preference, I do usually recommend the cyclic, just for the reason that you mentioned, where I also feel more comfortable or more confident if they're having a withdrawal bleed, and we know kind of with the timing of their withdrawal bleed, if we think that the progesterone component is sufficient. With the continuous, I would say, like, I guess it's presented as an option, but I personally don't use it very often. At the same time, I think if there's if there's no bleeding at all, like no breakthrough bleeding or spotting at all, then that's also reassuring. I had also spoken to a few gynecologists who had mentioned that for women where they were on estradiol and prometrium specifically, that they had actually had cases of endometrial hyperplasia. And so I think it is something that, you know, is something that needs to be watched for more closely, particularly with continuous regimen. From an endometrial point of view, what they had suggested was that they do think that some of the synthetic projections may be a little bit better in terms of preventing hyperplasia from that point of view.
Yeah, thank you. I think was sort of my concern, that I think there is sort of some recent worry a bit about endometrial hyperplasia with the continuous combined. So and some people that are already on it, now I find myself kind of bringing up that I would feel more comfortable if they switched to cyclical, but I wasn't sure if I'm being too cautious, but it sounds like you kind of feel similar.
I would agree with that. Yeah, for sure.
Any other questions?
Oh, hi, Angela. It's Marshall Dahl. Thanks so much for that great review. I guess my question had to do with women who present with secondary amenorrhea, where an immune likelihood seems common, where there's no clinical suggestion of a coexistent autoimmune endocrinopathy, and how you set up what initial screening tests or assessments you do for coexistent endocrinopathies, and then how often you test for other things subsequently, like what antibodies, things like that. Also, do you do ovarian antibodies? Is that a recommended measurement? Just kind of curious to know how to go about that. Thanks.
So generally, I would mainly just do the sort of the anti-adrenal and then the anti-TPO antibodies. We don't typically measure for the anti-ovarian antibodies, as far as we know. And then, you know, going from there, like with the anti-adrenal, I think if that comes back positive, it's quite strongly suggestive of an autoimmune POI, just with the strength of the association. And then with that, we would, you know, need to screen for Addison's, for example, on an annual basis as well. With the anti-TPO, I think it's a little bit more controversial just because it's so common. But I think, you know, some people may also call that sort of autoimmune POI. But, you know, I think it's a bit of a softer link to say whether or not for sure. And then beyond that, with some of the other autoimmune conditions that can be associated, like unless they have a history, then I wouldn't generally screen for them.
Great.
Angela,
Thank you.
What are you measuring in with the anti-adrenal antibody? What's the antigen?
So I think it's anti-adrenal or like 21 hydroxylase antibodies. So depending on the lab, they could send for one or the other. And I believe in BC, it's sent to Victoria, I think, to have it done.
I don't think I've ever ordered it. So you just order an anti-adrenal antibody?
Yeah, you just write, like, I guess the same way as for anti-TPO, kind of could write anti-adrenal antibody on the test and they'll come back either positive or negative.
Okay, thank you.
Okay, yeah.
Any other comments or questions for Dr. Liu?
Angela, I have a question. Just, I can hear myself echoing next door to you in the same office. For the studies you showed about the comparison with the oral contraceptive pill for bone health, do you know what dose of estradiol was used in those studies?
Yeah, so let me just pull that up here. Sorry, one moment. So essentially, so they did, the transdermal estradiol was 100 micrograms. I don't have the progestin, like the specific progestin or dose that they have listed here. And then the ethinyl estradiol was 30.
I don't know if others have had the same experience, but I find a lot of women have trouble tolerating 100 micrograms of estradiol. Often have to reduce the dose of it.
Yeah, I think I've certainly had that as well, where you know, some people do have difficulty. I don't know. I guess I've just tried to, you know, start with the very low dose, say like even like 25 or 50, and then go up really slowly and see if they do tolerate it. Sometimes I think for the spontaneous POI group, like say if they're presenting as a new diagnosis, say in their 30s, and they've had regular menstrual cycles previously, then they're more inclined to say to be more adherent, like they may have vasomotor symptoms and other things that are motivating them to take it. For the women with, say, like Turner syndrome, where maybe if they presented with primary amenorrhea and they never really had either regular menses and they don't get any of those vasomotor symptoms, certainly I think it can be quite challenging in terms of, you know, helping them stay on the medications. But, you know, I guess just time, very gradual titrations. And then sometimes for those groups, especially like younger, like young adults with Turner syndrome, if they find sticking with an HRT regimen is difficult and they're more open to taking a birth control pill, then I do present that to them as an option as well. So I think sometimes they see that their friends are taking it and they're more, I guess, open or willing to kind of go with that type of strategy.
So Dr. Pryor mentions that daily therapy is also possible, but I would usually continue with 300 milligrams of oral micronized progesterone. It's better if their bone density is low. That's the only schedule that actually increases bone in my experience. So that's her comment.
Good to know. Thank you.
I have one more question. With the patients who are diagnosed with Turner's, and who follows these patients? Would you follow those patients?
Yeah, so I mean, that's a very good question. So I think that was, you know, one of the areas where, you know, I think right now it's not super clear, given that they do have some of like all of these, you know, multi-system kind of comorbidities. So the way that the kind of multidisciplinary Turner syndrome clinic had been set up in Ontario was that they would be followed annually, and there was an endocrinologist and a gynecologist who worked in the clinic, you know, various people who would be there, along with a nurse and dietitian. So there's that sort of system. And then I think in BC, it would depend on, I guess, the individual physician or practitioner. I would be happy to follow them. So, you know, that's certainly an option. And then, you know, for some of their day-to-day or, you know, more routine care, their primary care provider would be very important as well.
So I think Dr. Pryor has their hand up.
Okay, that's great.
Thank you, Angela. That was excellent. My question is, if you were advising a pediatrician on when and what hormones to start a young woman with Turner's on, what would you advise?
So I guess if it's a young person, and I guess it would depend on whether or not they were prepubertal and they were, I guess, inducing or starting puberty, or if they were already post-pubertal.
No, they would be the average age at menarche, let's say.
Okay. So I think from that point of view, you know, it would sort of be pubertal induction, I guess, if they haven't started puberty spontaneously yet. And I think from my understanding, they're typically, you know, seen by pediatric endocrinologists at that stage as well. But I think the general guideline is starting with a very low dose of estradiol to begin, gradually increasing it. And I think a fairly common regimen that I've seen is that they would go up on the estradiol slowly as tolerated, like every, say, 3 to 6 months, something like that. Once they've been on the estradiol for about 2 years, or if they start to have breakthrough bleeding, then they would add in the progesterone at that point. And I think they also assess for things like breast development, so wanting to make sure that there's been some degree of breast development as well prior to adding in the progesterone.
Okay, my experience in the old days was that the young women that I was seeing from pediatrics were very short, had very large breasts, and had been treated with extremely low doses of progestins, if at all. And what I've learned recently is that the increase in bone density in puberty correlates with the timing of onset of ovulation. Therefore, you need to give progesterone, perhaps in low doses, starting much earlier than 2 years after they've already been on estrogen.
Okay. Yeah, no, that's good to know. I think one of the concerns that at least I had been told in terms of the delay was that they were wondering about impacts on, say, like tubular breast development and things like that. I guess if potentially the progesterone was started too early. And so that was the rationale that I had learned about, but perhaps there are certainly different strategies in terms of inducing puberty. Yeah.
Any other comments or questions? And for Angela?
Hi, Angela, it's Jordana. I just had a question. So I think the literature is pretty clear in terms of what to do with these women who have premature ovarian insufficiency, but what do you do in terms of women who are more like mosaic and where they might have like variability in terms of their periods and their symptoms? Do you modify your regimen at all?
So I mean, I guess if they're menopausal, it would still be kind of similar doses and regimen. But if they're still having a little bit of, I guess, do you mean if they're kind of more oligomenorrhea, like irregular cycles? Oh, sorry, I think you might be muted.
Can you hear? I'm sorry, I don't hear her.
Oh, can you hear me now?
Yes.
Yeah.
Yeah. Sorry, intermittent amenorrhea or oligomenorrhea.
Yeah, so with that, I think with the intermittent oligomenorrhea, I would treat sort of similarly, kind of in terms of doses, but I would favor the cyclic regimen. So that way, they're still having a withdrawal bleed like monthly, and ideally with that strategy, they won't have too much breakthrough bleeding or spotting on their own outside of that, though it's still possible, but certainly with the continuous, I would expect more.
Jordana, what a beautiful baby. What a beautiful baby. Well, I want to thank the Division of Endocrinology for attending endocrinology rounds. We hold rounds every week at Thursday at noon hour just to remind the division, but I think that's great support for Angela. So thank you very much for the presentation. Those of us that don't do this type of work learned a lot today. Those of you that do the work, I think you've probably learned a little bit as well. Next week's Grand Rounds is from the Division of Nephrology, and it's improving access to kidney transplantation. So thank you very much, Angela. And Jason Kong is here. My God, I haven't seen him for, oh my God. And he still doesn't speak.
I was going to say, I thought you were going to talk about the Chinese story, Dr. Kemp.
He still does. I'm not saying anything.
we want to go there. We want to go there during these rounds. But
no,
thank
all
you.
right.
Great
Thanks,
to see
everybody.
you.
Nice to see you guys. See ya. Take care.
Thanks so much. Bye.